see all of you.
Hello, everybody. Happy Thursday night. We were over here just chatting away, and then we thought about going live on Facebook. So here we are with the incredible Dr. Peter Litchfield.
Incredible.
Let me turn this off,
Okay,
and I'm going to introduce him to you guys.
Go right ahead.
So Dr. Peter Litchfield is the president of the Professional School of Behavioral Health Sciences, which offers professional diploma and certificate programs that integrate physiological and behavioral sciences for new and innovative applications into healthcare, human service, and performance enhancement. He is the CEO for Better Physiology, the manufacturer of capnotrainer instrumentation used for identifying and ameliorating dysfunctional breathing habits. Dr. Litchfield is a behavioral psychologist or physiologist specializing in respiratory psychophysiology and has lectured for more than 40 years in person and online throughout North America and in Asia, Australia, Europe, and Latin America to diverse audiences ranging from medical schools to corporate groups. So welcome. Thank you for being here with us tonight.
Well, thank you very much. And once again, I apologize, you and I together, for the mix-up here.
We're all good. Everybody knows. We're all good.
So first of all, just one question, and that is could you tell me what the background is of the people who are here? It would take too much time for everyone to tell us anything. I'm sure you all know each other very well. Yeah, so just in a brushstroke, what is the range of the backgrounds?
90% of us over here in the dental field, hygienists who are myofunctional therapists. We have some speech pathologists. We might have some dentists. Anybody that I missed? Once in a while, we have occupational therapists, physical therapists, chiropractors. We are a multidisciplinary team, and we gather at least 3 times a week now, and we have amazing speakers like yourself. We were doing it 5 times a week. We had 5 meetings a week, and I just cut it down because we were all going crazy.
Amazing.
So it's been super fun. We've had, I don't even know, I need to count how many hours we've done this because.
And where are most of you located? Are you in Canada, most of you, or where?
Most
Everywhere?
US, most USA.
Most US.
But we have a few people from Canada. Anybody else here from outside of the country? Dr. Tuesday, I know New York. Dr. Tuesday is somewhere else also. I'm not sure exactly. Marjara, I'm not sure where you're from. But yes, super diverse group. This is the most diverse you're going to get right here.
Okay, thank you very much for that. So first of all, let me just say something about the education that we offer in breathing science. And that is we have what we call a professional certificate in breathing behavior analysis. We have a certification program where a person becomes a certified breathing behavior analyst. And that professional certificate program is a subset of the certification. You do the coursework for the certificate, and then you do practicum work to earn the certification. Then thirdly, we have a diploma program, professional diploma program, which is really a 1-year program, but the certification is the first trimester of it. We're in a trimester system. That is 3 semesters per year. They're called trimesters. And so that certification counts towards that professional diploma, which then adds a great deal of other considerations, to what breathing science is about, such as doing EMG monitoring of facial activity and so on, and how that relates to developmental problems and all kinds of issues. But it goes way beyond the certification program. We've had a master's program for a long time in applied breathing science, but we gave it up because it took too much time. Most of the people we work with, not most, all of the people we work with are full-time employed, very involved in their professions, and they just didn't really have the time to put into a master's degree. It took a long time. So we did that for about 8 years. So we discontinued that and scaled it down to a diploma program. So that's where we are in the area of breathing. Breathing science is really my area of expertise that I've been involved in since 1984, and have become, very involved on many different levels, on the technology level, on the educational level, and then the providing of services. So if any of you are interested in this and really getting trained and bringing breathing science to what you do, please check us out at www.bp.edu. That's B as in Bravo, P as in Papa, .edu. And if you're interested in, we have a program starting up on October 30th. If you become sufficiently interested, you can go there and register, which is e-campus, which is our own proprietary e-campus, e-campus.bp.edu. Anyway, you can pick that up someplace else if you didn't get that down. So let me just start to talk a little bit about the subject. There's a tremendous amount of interest in breathing these days, more than ever because of COVID-19. No doubt there's all kinds of considerations. In fact, there's an article that came out in the Atlantic, for example, which is a literary magazine, or in the United States here, extremely well known, about COVID and how, in essence, they were looking at long COVID. What are the symptoms of long COVID? Where do those symptoms come from? What is long COVID really about? They really focused in a medical setting on trying to discover what that was about. And in the end, it was extremely interesting to find that the symptoms were a function of what we call hypocapnia. Now, hypocapnia is a carbon dioxide deficiency. Well, how are you going to develop a carbon dioxide deficiency? There's only one way to do it, and that is to overventilate. That is to overbreathe, what used to be known as hyperventilation, which is a clinical term. And this is not a clinical kind of consideration when we talk about physiology. It's about hypocapnia, which is a carbon dioxide deficiency. People learn habits to overbreathe. And the fact of the matter is, when you put a mask on, a lot of people feel air hunger, not because they aren't getting enough oxygen, but because they're claustrophobic. And one of the primary symptoms of claustrophobia is air hunger. So they experience air hunger as soon as they put the mask on. All the other people around them with the same kind of mask aren't experiencing air hunger. They're just fine. But these certain individuals are all experiencing air hunger. And then there's a belief system about, gee, I'm not getting enough oxygen. I have this mask on. I'm going to have to breathe more to get enough oxygen. This is terrible, with all the rumors that spread out there, all the pseudoscience that's out there. People believe they're not getting enough oxygen. So what they do is they take over the breathing. They take charge of the breathing. And as a result, they overventilate and they lose carbon dioxide. Or they feel air hunger and they immediately get in there to try to get more air. And they lose that carbon dioxide. And that, according to this article, was accounting, the hypocapnia was bringing on many of the symptoms associated with COVID-19. So it's really about a learned habit that people develop based on air hunger, based on belief systems, where they breathe more air, they feel more, why do they do it? They feel more secure, it reduces anxiety, they feel in control, they feel they're doing something to make sure they're okay, and what they do is they get into trouble immediately. Okay, and so I'm going to talk about those kinds of habits and how they affect us briefly physiologically, and some of the psychological part of it. That is, from my perspective, to understand breathing, you have to understand it as a psychophysiological phenomenon. You have to understand the psychology of it, which is about habits and other things. And you also have to understand the physiology of it. And most people who do breathing work don't know a damn thing about the physiology of it. It's all based on history, culture, tradition. This is what you do, to improve respiration. This is what we do in yoga. This is what we do in meditation. There's, several thousand years out there of doing breathing work. Let's learn from the masters. And most of that, if not all of it, is disconnected from the physiology of it. Okay, because you have two things here. You have breathing and you have respiration. They're not the same thing. They're not the same thing at all. Now, breathing includes respiration necessarily, but it includes a lot more than that. And an example of what it includes is trauma management. So somebody will essentially take over the breathing, lower the carbon dioxide level with very clear-cut physiological consequences, because the CO2, which is normally regulated by brainstem mechanisms, is controlling the pH in your body from moment to moment. It's not your diet, it's your breathing. From moment to moment, from breath to breath, it's regulating the pH of blood plasma, lymph fluid, interstitial fluid, cerebral spinal fluid. Where do I get that? Just pick up a textbook on pulmonary physiology, and it's all right in there. It's not controversial. It's fundamental textbook stuff. Okay, that's how you regulate pH. Pick up a book on acid-base balance. It's all about breathing, how breathing regulates it. That's a big part of any book on acid-base balance is breathing. And so breathing is about acid-base regulation. It's about getting oxygen to where it needs to get to, and it's about carbon dioxide management, because when you manage the carbon dioxide, you manage pH. So that's fundamental to respiration is pH management. And when you overventilate and you lose that carbon dioxide, the pH will rise. This is not good. You don't want to become too alkaline. This is a no-no. We hear a lot about how people are, their blood somehow is on the acidic side or not as alkaline as it should be. And everyone is pushing for alkalinity. No, please, no. Don't do that. You're going to get symptoms, and you may end up calling 911 and end up, in emergency. Because did you know that 60% of the ambulance runs in New York City are a function of people breathing too much? And they get symptoms that are so extreme that they're in an ambulance. They're too alkaline, not too acidic, too alkaline. And that will cause vasoconstriction in the brain almost immediately. And if you have trauma, you're suffering with trauma, and you start to breathe that way, it will lead to that constriction of the vasculature in the brain. And then what happens? You dissociate. You disconnect from your memories, you disconnect from your feelings, and you feel better, even though you've compromised the hell out of your physiology. And so this breathing is dysfunctional. It's serving you. It's serving you. It's the psychological part of it. It's serving you so you can dissociate, you can disconnect, and feel better. Okay, so now what this person does is whenever these memories start to emerge, or they have certain feelings, they breathe that way and they feel better. Now, how are you going to help that person? Teach them abdominal breathing? What's that got to do with the problem? You're going to teach them to breathe nice and slow and all that? What does that have to do with the problem? Zero. How are you going to understand that overventilation? How are you going to understand the dysfunctional breathing? By recommending techniques about how to achieve the right breathing mechanics? That's completely misses the fundamentals of what's going on for this person. That person is breathing a certain way because it's serving them in a powerful kind of a way. And if you want to help them with the dysfunctional breathing, you need to do a breathing behavior analysis. You need to find out, what is that person doing that's dysfunctional? What kinds of symptoms is it actually mediating? You don't guess. There's no guessing. What symptoms does that breathing actually mediate? You demonstrate it. And there are triggers for the dysfunctional breathing. Like what? I'm getting bad memories of what happened to me when I had this horrible experience. And that's the trigger for the habit. What's the payoff? I avoid the emotion. Breathing is psychophysiological. It's not just this physical thing. And a lot of people who think it's just a physical thing What they do is they manipulate it. I'm going to manipulate my breath so I can relax. I'm going to manipulate my breath so I can do X, Y, Z, improve my performance, stay underwater longer. Whatever it is, I'm going to do these certain things that's going to make me more successful in what I'm trying to achieve. That's how people approach breathing. They don't understand that breathing is a behavior. It is a behavior that is controlled by motivation, triggers, payoffs, all kinds of things. To really understand why a person is breathing the way they are right now, in this instance, in your presence, there's a lot of work that goes into finding out what's going on there. What's the history of a habit? Where did the habit come from? How was it established? How many habits are there? What kinds of physiology is it disrupting for that person? What are the symptoms that it is directly connected with? What are the things that sustain it? Okay, and you'll find that phobia is a big thing in breathing. Phobia. And if you want to address phobia, where do you go? You go into behavioral science, you go to behavior therapy. Those are the people who know about treatment of phobia. And you get phobia embedded in the breath. What you want to learn about is how to recognize and deal with a phobia. Is there a phobia? Where did the phobia come from? How do you address the phobia? What do you do to get rid of it?
I have
And
to.
so,
This is
pardon?
this is insane to me that you're saying this. I've been I was a mouth breather as a child, and I'm still a little bit of a mouth breather here and there. But it's so interesting to me everything you're saying, because even if I watch a movie or somebody underwater, I immediately almost start hyperventilating. I can't not even see a TV commercial of somebody just swimming fine underwater.
You're not alone. It's extremely common.
But now
So what you do is you address the phobia. Find the phobia and address it.
I almost drowned as a child.
Yep. There you go. There's a basis for having learned it, you see. So it really is breathing is a much more interesting subject than people give it credit for.
Mm-hmm. And
It's just about learning a technique that's going to relax you or something is just the tip of what breathing science is about.
look who's watching us.
I see that. Uh-huh.
You're a good friend. We have a lot of people on Clubhouse listening to us. Roger's here. Hey, Roger. Go ahead.
Well, great. So I was going to say that you have a lot of misunderstandings about breathing, like say mouth breathing. I just shake my head when I hear it a lot. When a dentist, because I've been working with dentists for a long time, what they have to say, or people who are in the dental field in general, what they have to say about mouth breathing is really very much off track, really, and so much of the time. They believe that many dental healthcare professionals and all kinds of colleagues in other healthcare sciences believe that somehow mouth breathing will cause overbreathing, for example, and that if you can learn to breathe in the nose, that will take care of the problem of overventilation. This is simply wrong. It's wrong. In fact, many times the way I get people to raise their CO2 level is to open their mouth, not close it. That doesn't mean I recommend that people breathe through their mouths, because there are all kinds of problems associated with breathing through the mouth that most of you know so well. But that's not the solution to reducing or increasing carbon dioxide levels or establishing good respiration. You see, we're talking about respiration here, where you need to have that CO2 within a certain range, where it may move around in the normal range, but you want it to be there, and you want it to be there whether someone is stressed, relaxed, excited, happy, miserable, depressed, doing exercise or whatever. You want that CO2 level to be stable. You don't have to relax to have good respiration. My God, most of us aren't relaxed ever. Does that mean that we have bad respiration? Of course not. There are reflexes that control it based on pH and carbon dioxide concentration, oxygen concentration. It isn't based on whether you're relaxed or not. Okay, so going back to the mouth breathing, you find if you did a correlational study, of which have been done, you find for sure that mouth breathing is significantly correlated with overbreathing. That's a fact. But that doesn't for a second mean that mouth breathing causes overbreathing. The real explanation is psychological. If you're afraid of getting enough air, what are you going to do? You're going to take bigger breaths. You might breathe faster. You're going to overbreathe is what you're going to do. If you believe you're not getting enough oxygen, you may switch to the mouth because it's easier. You're going to take deeper breaths because you believe that's going to help you, and so on. That's the logic behind why mouth breathing and overbreathing are correlated.
Wow.
So it may help some people to have them practice breathing in their nose, and sure enough, their CO2 level improves, but not because they're breathing through their nose. No, because they learn, they desensitize the fear that they have about breathing. So when they breathe out, and as you teach them to breathe slowly out and to keep their breath out, and they feel better, because what they do is they lose their fear by exposing themselves to what they're afraid of. It's like if you're afraid of dogs as a child, you give the child dogs to hold and they overcome it. So you get them down into that area of the transition between the exhale and the inhale, and they feel comfortable there. And so they no longer have that fear, so there's no need to reach for the breath. So in training someone to breathe through the nose, you may be doing desensitization training, and then you believe, oh my God, you see, it's the nose breathing that raised the CO2 level. No, it was the extinction of fear and a removal of the motivation to control the breath. And, how do you know that? Because, you're going to succeed a certain percentage of the time because you're going to address that anxiety issue when you get the person into the nose, but a lot of the time you will fail because it's not about reducing fear. Like trauma, for example, breathing through the nose isn't going to get somebody to breathe with proper mechanics, because that over breathing serves them in a powerful way. You're not going to get there by getting them into the nose. And I've got Buteco workers that I have worked with, some of the key names in Buteco, who when I work with them, I found them to be severe overbreathers, severe hypocapnia, very low CO2 levels, and they've been teaching their Buteco for years, and they themselves are overbreathing and not even knowing it. And one of the leaders that I worked with, actually, he was shocked. He was in our training program to get certified. And he was shocked that his CO2 level was so low. After all, he was an expert in Buteco. But he never bothered to measure his CO2 level. He never had a capnometer to even know it. And when he discovered it and we worked him up to higher levels of CO2, he had traumatic memories. He had traumatic memories, and he immediately overbreathed and went back down. He said, my God, no wonder I'm doing this. And then when he got into his nose, the whole mouth-nose issue was the same thing. That breathing through the nose hadn't helped him one iota. Nothing. Because the breathing itself wasn't addressed. His personal breathing and what it was about was not addressed. So how can you expect it to work? So in doing a breathing behavior analysis, you go in to try to find out what in the hell is going on here. What's motivating that person in the way they're breathing? You remember, most learning is unconscious. Most everything we learn in our lives is unconscious. There's only a few things. We go to class, we learn to fly an airplane, we learn to do dentistry, we learn these things consciously. But by and large, the emotions and the social behavior and all of that is learned unconsciously. So breathing behavior analysis is about going in there, doing a real assessment to find out what the hell is going on there. Because people breathe completely differently depending on the situation they're in. They may breathe perfectly until they stand in front of an audience to give a lecture. And they stand there and they can't remember what the title of their presentation even was. They're out to lunch. Why? Because they've lost 40% of the blood in their brains. Who can function with that? An example would be a guy who had a PhD in mathematics I was working with the US military. PhD in mathematics. I had him overventilate, so he reduced the CO2 level to a moderately low level. And I asked him to count backwards by 7 from 200.
I don't think
He couldn't do it. He couldn't do it.
That's insane.
A PhD in mathematics. He couldn't count backwards by sevens.
Wow.
And he said, my God, what's wrong with me? What's wrong with me? What's going on? So you're trying to give a lecture? You're trying to present when you're breathing like that? Now, on the other hand, to point out to you how complicated it can really be, or how interesting it can really be, some people will be better off giving their lecture when they're overventilating. Why? Because they disconnect from the things that bother them and worry them. So they actually calm down and they do a much better job. That's called state-dependent learning. That's a phenomenon that you need to know about to understand how breathing works. State-dependent learning. There's a huge literature on state-dependent learning in behavioral science. I don't mean 100 studies. I don't mean 1,000 studies. I mean thousands of studies. Okay, and so now what this next person is going to give a lecture and the CO2 level drops and they do a fantastic job. And other people are babbling idiots. So you see, that's what we call a type 2, that's what we call a type 3 habit, breathing habit, where you've learned to behave certain ways to the symptoms brought on by dysfunctional breathing. We have a type 2 habit where you say, well, breathing slowly is going to relax people and breathing fast is going to make people really anxious because breathing fast is sympathetic and breathing slowly is parasympathetic. What? What? That might be true, and well, it is true in certain manner of speaking, but you've missed all the psychophysiology of it. Lots of people who breathe fast have perfect respiratory chemistry. Lots of people who breathe really slowly are extremely hypocapnic. A lot of people, when they breathe slowly, become frightened. A lot of people who breathe fast feel more comfortable. They feel that everything is fine now, that they're breathing fast. You can't just say, breathing fast is going to make you sympathetic, you're going to freak out, and you breathe slowly, and that's going to be great. I mean, I just pull my hair out. It's just not understanding the phenomenon and how it works. Everybody wants to appeal to the autonomic nervous system. Hey, what about what's really going on, from a psychological perspective, as well as, my field is behavioral physiology. What is that? It's about how physiology learns. The physiology itself is a learning system. It's just not this plumbing system that does things according to code. It's a learning system. It's programmable. Physiology gets programmed all the time. A phobia is programmed physiology. Even though it doesn't make any sense to be afraid of dogs, you still are. It's programmed. And physiology is programmed all the time. That's my field. I'm 80 years old. I've been in this field for what? Since I was 25, in behavioral science. So what is that? 55 years. Okay. And so, that the physiology is psychological by its nature. That's what's unique about a living system. It self-regulates, not based on nothing, but based on its experience in its environment. And that is how physiology works. And we look at that in doing our work. Enough said for this evening. How long have I gone?
Oh my gosh. Seriously, I feel like you've been talking for 20 minutes, but it's been longer.
How long has it been?
Incredible. I think about 40, 45, guys. I don't even.
Okay. Well, see, I'm speaking off the top of my head. So, there's no slides. There's nothing like that. It's just me. So, if any of you might be interested in this, that we have our whole certification program that addresses how to do this work effectively in your practice. You can really address the issue, where you can at least, identify the issues through an assessment and pass them on to the breathing network the national network we've created, and someone else can provide the services. But anyway, there's all kinds of directions to go with this.
So people are freaking out right now, and we have lots of questions. Do you have a little bit of time, Chad?
Oh, I do. I'm here.
Okay, awesome. So first question, Anne asks, what does a breathing behavioral analysis look like?
What does a breathing behavior analysis look like?
Mhm.
Okay. We have we start before it's called a breathing interview. And that's where you start for an assessment. You start with an assessment. And we have forms, 2 forms. We have an abbreviated 1-page form, and then we have 2 larger forms that we have a client fill out first, because that is the basis for the conversation. We have a conversation with our client. Okay, one's a checklist of symptoms and deficits. And it's not just, I get dizzy, my lips turn blue, and all these different things. But it also asks them, because there's a list of situations in which they experience them. And they have numbers. So they indicate with the numbers what situation they experience all these symptoms. And also how frequently do they experience the symptom. And you would be amazed how much you learn so quickly. But you learn that they're suffering with dizziness. But you know what? It's only when they're in social situations that they get dizzy. Now, how could they get dizzy in a social situation? How could the physiology change to make them dizzy? There's one clear-cut way. Just take a few deep breaths and you're going to get dizzy, because you're going to lose blood in the brain. Not only are you going to lose the blood in the brain, but the red blood cells in the brain, the hemoglobin is going to be less likely to deliver the oxygen because the red blood cell is too alkaline.
Wow.
Okay? So you see all these symptoms, and you have the situations that in which these symptoms occur. Now, it might be that dizziness is something else, something to do with blood pressure or something like that. But you could quickly sort that out. There's nothing to it to find it out. So you have the checklist. You have another form. It's kind of a medical history, because what that's about is trying to discover where the habit came from. Like you said to me, Renata, am I pronouncing it correctly? Renata said about she had a near a drowning experience. Mm-hmm. See, there's a place where you could learn it. I know. He was a famous quantum physicist I worked with a long time. He's a very close friend of mine. He had, he had sleep apnea for years and years and brain fog in the morning. And he thought of himself as an expert in breathing because he got really interested in CO2 and got capnometer. And he worked and published some articles with my closest friend, Bob Freed, and they worked together and everything. And I was doing a workshop with Alex, And I had him, I had this sheet in front of me, and I saw he had asthma attacks when he was a child at night when he was a child. Okay. He had asthma attacks. So I had him lay down, and his CO2 levels were perfect. But when he laid down, he went into extreme hypocapnia, and he couldn't control his breathing. It was like this learned habit that just raised its ugly head like a phobia, and he couldn't function. So what happens at night when he lays down, he immediately overventilates and goes into hypocapnia. No one ever bothered, no one found that out. How long did it take me? Well, it took me 1 minute to realize that there was a problem, when he was a child, the brain fog and the sleep apnea, and he'd had that. And when he laid down, I saw his CO2 level. After 5 minutes, we were on to what was going on.
Yeah.
We're looking at it as a psychophysiological phenomenon and looking at the variables that were involved with it. I had another woman who was coughing all the time, just constantly coughing. And her nephew told me that she'd considered suicide. She couldn't handle it anymore. And she was in her 70s. And when I met with her, I asked her, I said, this is during a breathing interview, you see. And I saw that. I coughing was the issue. I said, well, when did you start coughing? She said, in my early 20s. And I said, well, do you remember, what was going on? She said, oh, yeah. I used to do it on purpose. I said, you did it on purpose? She said, yeah, I was kind of an immature teenager and young person. And that's how I could get attention from people.
Wow.
I said, you're serious? And she said, yes. And I said, you don't understand where your coughing problem came from? She said, well, yeah, I guess I do. I guess I do. I never thought about it. This is 2 minutes into the interview. So right away, we were on to what the coughing was about. She'd been medicated, seen all these physicians and everything. And, 2 weeks later, we gave her a diary. We did these different things with her. She wasn't coughing anymore.
Wow.
After 50 or 60 years,
Wow.
I can't tell you how many surgeries have been canceled. If you want to go on our website of the instrument website, betterphysiology.com, you can go there and listen to an interview I did with Denise Campbell, where there was a woman was scheduled for surgery because she had had a severe accident and had all these different symptoms. But Denise, in doing some movement work with having her lean back and so on, without going into detail here, she discovered that the symptoms were generated by the way she was breathing 100%. They canceled the surgery. They assumed the symptoms had to do with her injury when in fact they were learned breathing responses, learned breathing behavior, like in the case of COVID and long COVID, to the pain problem that she had. They were learned kinds of breathing behaviors that brought on the hypocapnic symptoms. I mean, the list just goes on and on. Anyway, I want to answer that question. You do this interview, you look at the history, you look at the symptoms, you do testing. There's certain testing procedures that we do. We'll bring the overbreathing on purpose. We'll have the person overbreathe, and then it'll produce the symptoms that they suffer with. And they go, my God, this is exactly what I feel. I'm making it short and too simple. But we do all kinds of testing. And then when the assessment's done and the client determines for themselves that, yes, I have a dysfunctional breathing habit, because it's about self-exploration. They say, what can I do? And we say, well, we have a tutorial program where you can learn to breathe. You can learn to disengage that habit that you've just seen. And where you can replace it with a habit that operates in concert with the right respiration, with good respiration, so that the breathing mechanics are in the service of the chemistry. And that is really the huge theme here. The mechanics by themselves, if you don't consider the chemistry, what the hell are you doing? Really? What do you think you're doing? I mean, you manipulate all these mechanics and you don't understand how you're affecting the respiratory system. That's almost, it's really ultimately unethical. You think based on what? That somehow these mechanics you're teaching are good. Who told you that? Those mechanics need to be consistent with the respiratory requirements. You aren't looking at it? What are you doing?
Mhm.
And you guys, you look at airways, for example, the size of an airway and all that, and you assume that the diameter of the airway somehow has to do with the breathing problem you're looking at. Think again. Think again. How much oxygen does that person really need to bring into the lungs? What is the usual restriction in respiration? What normally restricts it? What when you get out of breath? What is that about? You're not getting enough air? Wrong. You're not getting enough what? Blood. It's a circulatory issue. It's not a breathing issue. For every liter of blood that you pump into the capillary system, the pulmonary capillary system, you can move 20 liters of air. And how many liters of air do you need for 1 liter of blood? 1 liter of air. So you have 19 more liters that you can create, that you can bring in. So when you're running and getting out of breath, it's not that you can't get enough air in the lungs. So you can't get enough blood to move through the capillary system. That's the problem. So when you talk about airways, if someone feels restricted for whatever reason, they may start to take deep breaths because they get air hunger and they believe they need more air. Now, a lot of people don't get air hunger, some do. This is a psychological thing. So, it might be, going to make the airway wider. It might be completely misguided surgery, unnecessary, and absolutely contributes nothing in regards to that person's ability to get the air they need. So these are things to be aware of. If you're interested in breathing in your field, it behooves you to understand respiratory chemistry because those mechanics have to serve that chemistry. That is my message.
Wow. I want to ask about the capnometer and
Sure.
some other questions. But can you tell us about the capnometer real fast?
Yes, I'm going to add one more sentence to that person's colleague's question. After this assessment, then they go through a learning program where they learn to disengage that habit and replace it with other habits that are in concert with respiration. That's what we do. In the breathing behavior analysis that moves in to what we call behavior modification, which is a huge field in behavioral science, psychology, and other fields as well. Okay, go ahead. About the capnometer. Well, capnography, there's medical capnography, because capnometers are used in every surgery room probably in the world and is used in, most ambulances. It's used in critical care. It's used in emergency medicine. They're everywhere. Okay. And there are many companies that make all kinds of capnometers. What we created was a capnometer for doing what we call educational capnography. And the capnometer is used for identifying dysfunctional breathing habits. It's not for monitoring blood gases during surgery. It's for looking to see whether there's dysfunctional breathing from a respiratory point of view. How do you know whether the breathing you're looking at is dysfunctional from a respiratory perspective? There's only one way. That's with a capnometer. An oximeter? No. Oximeters tell you virtually nothing about learned dysfunctional breathing. You know, one of the owners of Better Physiology, one of my colleagues, he and his friend invented the pulse oximeter. So we know a little bit about it. Okay, so the oximeter is extremely useful instrument. You know, don't get me wrong. I mean, it's too bad my friend sold his company, I think in 1984. He would be a billionaire today, but he didn't think that far ahead. I guess he needed the money in the moment, so he went for it. But anyway, so so what we have software, which is it's a management system, and it manages uh, therapists and clients all together, where therapists have logins and clients have logins, and all the data is collected in the cloud. And you know, all kinds of people can go in, depending on who they are, and look at the data. All kinds of reports that can be created. But the software on the computer, whether it's a PC or an Apple, also cell phone, where you can essentially do work with people to identify the dysfunctional behaviors and identify the triggers for them by monitoring the CO2 in real time. And then the person, your client, can see what's going on, and they relate to what they're doing. There's all kinds of protocols you can learn to help people restore good CO2 levels. And there's all kinds of tests that are embedded in the software for doing breathing testing. There's all kinds of protocols for learning that are built into the software, where you can work with your client. Clients can rent instrumentation and take it home. A lot of people rent instruments, and that's a good source of income for the business to be able to rent capnometers. And then all the data that is when someone's working at home, the data goes to the cloud immediately, so the therapist can go in and see the data immediately as to what's going on, and so on. So it's an extensive software system. It's a way of identifying dysfunctional behaviors, not just seeing whether the CO2 is where it's supposed to be. And you can when you look at the waveform of the CO2 signal, you can see aborted breaths, which is a common thing. People, they abort the breath and take the breath. You can see people who push the breath. A lot of people have a habit of pushing the air out. Why? Because they're trying to get it over with. Yeah, they get it over with. They feel better, so they can take the next breath. And what they do is they end up overventilating. So they push. You can identify pushing, holding breath, aborting the breath, all those things.
My goodness. I know there's a lot of people that want to talk. Dr. T is on Clubhouse right now and he's listening. Dr. T is a dentist in California. Dr. T, you can talk.
Okay, very interesting. Yeah. So basically from what I gathered and I agree is that almost like CO2 is more important than oxygen because it's the best vasodilator together with the nitric oxide.
Absolutely. And that's another thing. I'm glad you mentioned nitric oxide, because overventilating alters the chemistry of the red blood cell, and that is the hemoglobin. And the hemoglobin is less likely to deliver nitric oxide that it carries, in addition to the fact that when the CO2 level drops, the epithelium of the vasculature doesn't generate the normal level of nitric oxide, so you get vasoconstriction very quickly.
Okay, so this is okay. So I know when you mentioned the breathworks and stuff like that. So in defense of the people who are doing breathworks, and if they do it the right way, I don't know the right way, but this is how I understand it, right? So when we do breathworks, so the most important thing really is, because I agree with everything, and when you especially when you mention dysfunctional behavior, because the orofacial myofunctional disorder for us is not a disorder, but it's a behavior created by produced by the brain as a response to something that from a function that was lost, and this function is actually the function that was recovered from a function that was lost.
Your voice is warbling away from us. Sorry.
It's starting to break up. There you go.
Am I?
Yeah, I understood, but your voice literally became like from an alien location, on another planet or something.
How am I?
But
Yes, yes, they did not.
Okay. All right. So when we encourage people to breathe in, exhale, and breath hold, the best part of that inhalation, exhalation, and breath pausing is actually the breath hold. Because as you hold your breath, you keep your carbon dioxide in your blood. And as you keep your carbon dioxide in your blood, it actually helps to disengage the oxygen from the hemoglobin. So that
yes, that's right. It does. But the problem with that is, I mean, that's true. And I always point out how breath holding can actually serve people who have breath holding habits. But what it really implies when people hold their breath is that they're controlling their breath. And when they try to control the breath, then they decouple the chemoregulatory system in the body, so that the pH level and the CO2 level and the oxygen level no longer are the primary regulators in the situation, and they can easily get into trouble. So that is often a sign of dysfunctional breathing, not that the breath holding itself is creating a problem, but it is the motivation behind it that can create the problem. And so what happens when you teach people to hold the breath to control CO2, then they're right back to their belief system around how they have to do it or it won't happen. And that is usually the basis for a lot of dysfunctional problems, is because they believe they're the ones who have to do it or it will not happen. They have to do the breathing rather than allow the breathing. When they allow the breathing, they get the mechanisms, the brainstem mechanisms can come in and do their job. Unfortunately, it's more complicated than that, because often allowing it is something that the physiological system has to learn as well as the individual, because so much of this learning is unconscious. So there's more to it to get the person through it. But the idea is to make breath holding unnecessary, and that basically the reflexes can come in and do their job, and that they don't think about, I better start breathing in a particular way, but rather it's automatic. I work with the U.S. military and the special forces, where they have a whole program now they've introduced as a result of the master's degree program that we offer, that some of them went through. And it's all about when the special forces person gets out there, that they don't have to think about manipulating their breathing, because they're in a crisis situation, and then they automatically breathe in the correct fashion. They're not thinking about a technique. They are their breathing. They be their breathing rather than manipulate and do their breathing. Hold on, my headset is going to stop working. I have to plug it in. Just 1 second. I've got to.
okay. I agree totally with that. So sometimes we have, because
Hold on 1 second. Hold on 1 second.
Just a second, Dr. T.
Okay, I'm back. Go ahead. Sometimes I got sometimes.
Okay. Everything is rhythmic, right? So chewing is rhythmic. This is all from brainstem. Swallowing is rhythmic, and breathing is rhythmic. Walking is rhythmic, and that is brainstem. And that's why I agree with you. Everything is automatic. But sometimes we have to transition those patients when they have.
Sometimes that's right. The self-interventions at times, like for example, if someone has a phobia embedded in the breath and they overcome the phobia, well, that phobia may pop right back into place, because we know in psychology how tenacious phobias are, and in certain situations that haven't been addressed, they pop back. And I can think of my own life in skiing, where I developed a phobia, where some people when I was young pointed me down a hill on a black run, and I lost control and I hurt myself, and it was a mess. And then I tried to ski later on, and I had this phobia. Well, I overcame all of it except one little piece of it that would come back in flying colors under certain circumstances. I'd be on a black run and it would be icy, and the whole phobia would just flip back. Okay, so those self-interventions become really important in those situations, which happen a lot in breathing. So you need to then come forward with them to help that person bring back that CO2 level. And of course, then they feel more confident also, because they have a technique that in case of emergency, they can use that technique.
Agree, because when we do this is always, and I always believe in this, and I agree a lot with what you say, because like I said, that those PTSDs, those phobias will always come back when there is a perception of threat, and because if it's a behavior, because the brain will automatically and habitually resort to something that is familiar, which is like unless you train yourself, or and you do therapy and you include the brain. And if you don't include the brain in your therapy with your breathing, because breathing is in the brainstem. So what we do is we transition them, and then instead of breath holding now, we don't do the breath holding, because I agree with you. It has to be automatic because it's brainstem. It's autonomic.
Right.
This is how we transition them. So we tell them to inhale, and then exhale, and then swallow. The swallow stops your breathing, and that is normal physiologic. And that's the reason why when we do therapy, we coordinate functions like breathing, swallowing, chewing, because you can't just function by one. They all coordination of each. So you don't say you hold your breath. No, you transition them with that, but just to give them the idea of, hey, we want to make sure you hold your breath, because in normal physiologic function, when you eat something, you inhale, you exhale first, and then you swallow.
Well, we see a lot of people learn over ventilating when they eat, because there's fear that gets embedded with not getting the air they need. And by the time they finish eating, they're in a hypocapnic state, and they have all kinds of issues. I have all kinds of cases I could mention on that. Yeah, I think when fear gets involved in that whole sequence of things that you talked about, then things really get disjointed and become disorganized and no longer flow rhythmically in the way that you were mentioning.
Mm-hmm. And the reason why it's like this: if there are no safety cues when you do normal physiologic functions, and there are no safety cues, the brain will always step in, and because it's neuroprotection. So for example, if you inhale and then you swallow, the brain, you will develop that phobia again, because that's not how it should be. Because when you inhale and swallow, the brain would say, hey, if you inhale and then you swallow, there's a potential that you're going to have, it might go to the wrong pipe. So the best...
there is,
right?
Yeah, for sure.
That safety cues. So what is the safety cues? Let them inhale, short, and then exhale. After you exhale, you swallow. That means now you're creating that safety cue, and then the brain is going to think, okay, I don't have to react. I don't have go ahead and continue with that rhythm, because once you exhale and swallow, there's no way it's going to go to the wrong pipe. But if I inhale and swallow, inhale is air for airway, and I swallow my food, which is food, it should go to the foodway, which is esophagus, instead of the airway, which is the lungs. So that's why the therapy the reason why I got involved with so much brain behavior, it's because you need to create safety cues so that you're not going to be phobic. You're not going to be PTSD.
So you're talking psychophysiologically. You see, from my perspective, you say safety. This is a psychophysiological consideration, and that's how I look at all of physiology. Really, is psychophysiologically. It offers so much more in understanding how and why physiology does what it does. But just to interrupt you for a second, do you know, since you're in California, you're a dentist and you're interested in these things, do you know Mark Cruz?
Yes.
The airway medicine guy? Yeah, I'm very closely connected with Mark.
Oh, okay.
And do you know, but Barry Raphael back in New Jersey, he works with Mark. He does the eastern branch of what Mark does in the west.
But I do entirely different from them. But you are such a breath of fresh air, because you are such a breath of fresh air. You speak my language. Finally, somebody's speaking my language.
That's wonderful. Thank you. Well, you speak my language. I can see. I speak the same language.
Yeah, I'm glad I found someone like you. But here's the thing. It might be really revealing for some of us here in the airway. But I've been quiet all along just because we might be somebody controversial. But these are all physiologic. But that's why I'm kind of being quiet a little bit. I don't want to get up because somehow right now we're not talking about brain behaviors, and that's why this disorder is not a disorder because most of the orofacial myofunctional disorders is actually produced by the brain, and when they become a habit, they become a behavior. So I call it more than disorder, but I call it orofacial myofunctional behaviors because there's a loss of function.
I think that puts it in much better perspective.
Yes.
Dr. T, thank you so much. Dr. T, yes, he doesn't speak a lot, but when he does, everybody listens also. Thank you so much, Dr. T.
I don't know how you found her, Renata. I know how you found Renata.
Well, I know everything.
I know.
But it was actually Lyle that reached out to Dr. Peter Litchfield, so we're very excited. I know you and Roger worked together for a long time, and you both are fantastic. We're going to do one more question, and we're going to wrap it up, and we're maybe going to have you guys come back because there's so many questions, and this was such an incredible meeting we had tonight. There's a couple of people with the same question, and it's regarding swimmers and athletes. How does this relate to athletes and playing sports? I'm being asked which is better, nasal or mouth breathing.
That's quite specific. By the way, I've just put my email into the chat message.
Okay.
And so if you want to email me and you're interested in our training programs, you can just email me there and I'll get you what you need. We have our next one starts October 30th. So that question regarding,
if you can send information, we'll put our Airway Circle group. We have about 1,200, I think, Airway professionals now in our private
group.
Group.
Wow, that's impressive.
Yes, we grew super fast, and it's awesome. It's very engaging. Everybody there, like we're all, everybody answers, everybody talks to each other. It's super cool. You should join us.
Well, thank you very much. I'm going to, since I'm right here, I'm just going to upload the brochure for that program, if that's all right with you.
Yes, of course.
Okay, here it is. I'm just pulling it up. Okay, let's see. Here it is. Here it comes. There is a brochure right there.
Awesome. Okay. Ange, would you post it for us, Angela? Do you mind?
Okay, the question regarding nose and mouth breathing. Which is preferable? Well, nasal breathing is, always preferable when you can do it. A lot of times we can't, like when we're talking. That's one of the objectives of breathing. It isn't just respiration. Talking. Without breathing, there is no talking. There are many purposes for breathing the way you breathe. So, nasal breathing is clearly preferable, although there are times when you do need to mouth breathe. Clearly, if there are obstructions in the nose or something, you may have to switch to the mouth. But nasal breathing is preferred for lots of reasons, and one of them that people. Sorry, that's something I was thinking of abdominal breathing, but the simple answer is nasal breathing. I mean, it's preferred in most any situation if it's possible, and it is in most situations. So what happens is a lot of people, the CO2 will regulate when they breathe through the mouth. Why? Because they stop worrying about getting enough air. They get into the nose and they worry about getting enough air. They feel resistance. They get air hunger because of the resistance, just like when they put a mask on. Not true for you or me, but for them, yeah. They put the mask on and they had air hunger. They breathe through their nose and they get air hunger. They switch to the mouth, CO2 level comes right up. Because when they feel that resistance in the nose, they try to get more air because they think they're not getting enough.
Wow.
They feel like they're not getting enough. They don't have to think it. They can feel it. That translates into not getting enough. But of course, they're getting all they need, but they're losing carbon dioxide. Now they get symptoms, and then they attribute those symptoms to other causes. They don't think it has anything to do with the breathing. They think it has to do with a pain issue or a stress issue or relationship issue or who knows what.
Wow. Everybody, let's keep any other question that we have for next time because it is getting late and we have taken a lot of your time already. But I am so appreciative of you for being here last minute, just joining us and still, giving us so much. Thank you. Thank you. Angela,
Welcome.
your brochure on our group, and we invite you to come back and come hang out with us. We have fun here on Airway Circle.
Well, thank you very much. Send me a link to the recording if you would.
Yeah.
Okay.
All right, awesome, guys. Thank y'all so much. Have a wonderful night. Let me tell you really quickly what do we have going on this week. Tuesday, we have Dr. David Page, who's going to be talking about vitamin D deficiency. Super excited. If you guys don't know Dr. David Page, you need to look him up. And then on Thursday, we have Dr. Tara Urson, who's going to be talking about the team of professionals around tongue tie and phreniectomies. If you guys are not members of Airway Circle yet, we're trying to reach 100 by the end of the month, and I know we can do it. It's only $25 a month, and you get access to all of these amazing recordings, and Clubhouse recordings, whatever we have available. You have product discounts and our research folder, and plus you just get to be a part of us. It's we have fun here and we're super cool. But anyways, go on our website, airwaycircle.com, click on members and click on join now, and we will see you guys next week on Tuesday. Thank you so much. Have a wonderful day. Thank you, Dr. Litchfield.
You're welcome.
Bye-bye.
Take care.